I'm Chris Antenucci. I am an addiction medicine faculty at MetroHealth. I work in the outpatient recovery program. I have nothing to disclose. Um, Today is about treatment of addiction. I'm going to talk about types of treatment, focusing on medications, behavioral treatment, and also peer support. Just a quick review. Not everybody that uses substances has addiction, has a substance use disorder. The most commonly used substance is alcohol. Next would be THC and cigarettes, and then cocaine. But substance use is a spectrum. There's lots of people that abstain or use socially, and then some people who use in a risky manner or heavy use, and then some people who actually have addiction. And people move back and forth across this spectrum in their lifetime. Addiction, as we talked about, it's a chronic disease. It's a relapsing illness, just like we were talking about in the beginning. You know, there's going to be periods of doing well and periods of struggling. It's a brain disease that affects the neurons that communicate sort of from your reward center to your frontal cortex, your decision-making center. It's super common addiction. About 10% of people will have it in their lifetime. That doesn't mean they'll have it, you know, actively their whole life, but at some point in their life, they will have it. It's usually due to a combination, about 50-50 in terms of genetics, and then sort of life experiences, trauma, things like that. Again, like we talked about before, the definition of substance use disorder is you're using and you've lost control of the using of the substance, and you're using despite side effects, and you have tolerance and dependence, sort of like that case we were discussing at the beginning. That sounds like somebody who is struggling with severe addiction and struggling with their motivation for change, their readiness for change. Most people who have addiction don't get treatment, even though we have good treatment. There's a combination of the patients feel shame, and providers tend to have a lot of stigma around judging people who struggle with substance use disorder. Substance use disorders, like we've talked about, they're super common. About 10% of the population has it at some point in their lifetime. As soon as somebody sets foot in a clinical setting, the odds that that patient has an addiction or a substance use disorder is even greater. 20% in primary care, 40% when you're in the hospital, for those of you that are doing, you know, inpatient work. And then if you're in the ED setting, you know, the odds are really strong that there's some sort of addiction issue for patients. What this means, though, the fact that we're not recognizing it, that we're not diagnosing it, that we're not offering treatment, is that lots of people are ending up having complications like hepatitis A, B, C, HIV, legal issues, job loss, housing loss, relationship loss, flare-ups of their mental health conditions, and the biggest risk, obviously, is of uncontrolled addiction is death. Ohio is number 7 in the United States for overdose fatalities. This map is from 2018, but the current map is still pretty similar. So you can kind of look on there, see your county. Hopefully it's not too small, and sort of see where you rank. The darker the color, the higher the rate of overdoses in your particular county. And unfortunately, despite all sorts of efforts, the overdose rate is continuing to rise. Fentanyl is the number 1 cause of overdose. Some of it's intentional fentanyl use, you know, people with opiate use disorder who are either injecting or snorting fentanyl, but some of it is accidental fentanyl use. And we've mentioned this in other sessions, you know, people who either have had fentanyl without their knowledge or interest has been cut into their cocaine or their THC. So they're trying to use THC or cocaine, it's got fentanyl in it. And then the other big source of accidental fentanyl overdoses are people where they've pressed fentanyl pills and sold it as Xanax or Adderall or Percocets. They can look very, very convincing. And I've definitely had more than one patient who swore that they were taking Adderall and their urine had, you know, high levels of fentanyl in it. So not all overdoses are fatal. We try to prevent overdoses with Narcan and test strips, and we can talk a little bit about where you can access both fentanyl test strips, salazine test strips, Narcan. So that can help prevent a fatal overdose. And if you can keep somebody from having a fatal overdose, then there's always the option that they will end up getting treatment at some point. Hard to always say when a patient's going to truly be ready for treatment. But if you got to keep people alive in order to be able to help them recover. So if somebody has an overdose, it is a non-fatal overdose. It's a red flag that they're at high risk for a fatal overdose in the following 12 months. So about 20% of people will die in the year after their non-fatal overdose. So it really needs to, grab your attention if somebody's had a non-fatal overdose, that they need help, and they need help now. With medication, we can cut that in half. So going to talk a fair amount about opiate use disorder medication, because it's so life-saving and it's underused, unfortunately underprescribed. Briefly, we talked a bunch about addiction screening last week. I think the main take-home message is ask everybody yearly. If you have regular patient panel that you're in contact with, make sure you're checking in with them yearly on their substance use habits. And then like Pat said, then and others said last week, you're asking and then you're listening, and really listening. And if somebody reports that they have heavy use, frequent use, get some details and try to sort of figure out, do they need treatment? SBIRT, again, is not something that one person is going to go and do all by themselves. It would be a system. So you can certainly discuss it with others at your clinic if they're interested in doing sort of the screener, the assessment tools, the interventions, and the referrals. But it is a good method for making sure everybody gets screened equally and everybody gets equal access to treatment, by having a universal tool in place. So addiction treatment does work. There's lots of good treatment. There is no silver bullet where you're just going to treat somebody one time and they're cured forever, unfortunately, but there is good treatment. And it's just one of those things where you're going to have cycles where you need to repeat the treatment because somebody's struggling. But people can recover with the help of medications and counseling and peer support. And the counseling can be done in a group, one-on-one, same with peer support. You can go to, AA or NA or self-help meetings, or you can have a one-on-one peer coach if you're not a meetings person. So there's lots of different options for recovery. In terms of the FDA-approved medications for addiction, we have good medicine for nicotine, for opiates, and for alcohol, that are available to us. The medicines for nicotine use disorder, I'm not going to spend a ton of time on. I'm assuming you all are already pretty familiar with these. But, there is nicotine replacement therapy. There is Chantix, also known as varenicline, and Wellbutrin is kind of a second line. The ones that work best are really nicotine replacement and Chantix. And then some patients use vaping, because it's cheaper, it's easier to access. And the goal for a lot of these patients is the vaping is kind of like a nicotine replacement therapy. There've been some studies that show that that can be useful. The trick with vaping nicotine, instead of like chewing nicotine gum or getting a nicotine patch from your doctor, the trick with the vaping is you really have to know the contents of your vape pen. A few years ago, there were vape pens that had vitamin E oil in them, and people had horrible lung disease and died. More recently, I've had patients where they're using gas station vape pens and they think it's nicotine, but it's got all sorts of different contents, including fentanyl. So you really, you have to know where you're getting your vape pen and what's in it in order to be successful at getting off of cigarettes and weaning your nicotine. And again, we can talk more about nicotine if that's something that's useful to people. But in addition to medicines for stopping nicotine, we also have you know, there's smoking cessation classes, there's the 1-800-QUIT line. There's lots of apps and phone, you know, tools that people can use. So there's lots of different things that are out there to help people quit with nicotine.
And Chris, quick question.
Yeah.
Where can we get access to the test strips?
Yes. So usually if you're in and I'm going to have that at the end, a whole bunch of resources, but often your Department of Public Health is a great resource. Your Adams Board in your county is a great resource. I could rattle off all the places in Cleveland, but that's not going to be helpful to the rest of you. But when we get to the end, I will spend some time on those slides about test strips. Medications for opiate use disorder, there's 3 of them. The methadone, I'm not going to talk much about because that's really, it has to be in a specialty clinic. So those are federally regulated, government approved specialty clinics where you can use methadone for opiate use disorder, and you can't use methadone outside of those clinics. Although the laws are hopefully changing, they're under review. In terms of the 2 more commonly used ones, are buprenorphine, which can either be Suboxone or Sublocade. It can be a pill, a film, or a shot. And then the naltrexone, which is an injection. And the naltrexone is a complete blocker. It's also called Vivitrol. We tend not to use that as much because it's hard to get people started on it because they have to be sober for 2 weeks before they can get their naltrexone Vivitrol shot. So all 3 of these methods work pretty equally. They're all very effective. You only need to treat a couple people to save a life. But access issues are, you know, access to methadone makes it harder, particularly for those of you that are working in rural areas. And then access to Vivitrol is tricky because people have to be sober. And usually the only people who come to me that don't have anything in their system are people that maybe were recently incarcerated or in a controlled environment. And then they have the option of Vivitrol if they want that instead of buprenorphine. But all 3 work very well. The way they work is they help prevent withdrawal. They help stop your cravings. They're very safe. And they also, if you slip and use opiates, you're not going to feel much. So I know my patients on the right dose of medicine, if they tell me, oh, I ran into an old buddy, we did a little, you know, fentanyl and I didn't feel much, or I just wished I had my money back, then I know they're on a good amount of the medicine that's kind of protecting them while they're in early recovery. Usually the medicine isn't for a lifetime, but honestly, it's really up to the patient how long they want to be on the medicine. I have some patients who are on it for a year to just kind of let their brain heal and give them a chance to fix their life. But I have other patients who've been on it for 10 years. So it's really an individual decision how long to be on the medicines. We know that these 3 medicines can help you use less drugs or no drugs, have better employment, housing, less legal involvement, and less likelihood of getting hepatitis C, HIV, hospital stays, emergency room visits. So, and obviously, as we've already talked about, they also help people stay alive. One more slide just to kind of get the message across. If you look, the green bar is the general population in terms of, you know, people that die within a year. That's sort of the baseline. Without treatment, you've got the red line of how many people are going to die in a year. And then the blue line is with either methadone or Suboxone. You've kind of taken that red line and pushed it back almost to normal, almost to a non-opiate use disorder patient. And yeah, so you take that 6 times normal death rate and you can push it back to less than 2 with medication. Why don't so many people get medication? I think, again, a lot of it has to do with stigma. I don't know. You can raise your hand if you've heard somebody say this. I know I heard it right in the beginning when I was learning about addiction care, but they were like, you know, this was actually at a treatment facility. Somebody was sort of like, you know, I don't believe in Suboxone. You're just replacing one addiction with another. So I'm guessing lots of you have heard that. There's this idea that if patients are on medication, they're weak or they're still addicted. And it's just not true. It's it's an FDA approved medication for a chronic medical condition. Um, the trick is when you're on buprenorphine or methadone, you are dependent physically on the medicine. If you stop the medicine suddenly without a doctor's help, you're going to have withdrawal. So you are dependent on the medicine. You do have, physical dependence on it. But you're not addicted because you don't have loss of control. You're not having negative consequences, and you're not having sort of that increased tolerance where you need more and more and more. So really, I think of it more like insulin for diabetes. It's a medicine that helps you with your chronic illness, and you do depend on it to be healthy, to live. But you're not addicted to insulin when you have diabetes. And I would say it's the same idea with methadone or buprenorphine. And by buprenorphine, I mean Suboxone or Sublocade. And then this is again just a quick slide to show a few more of the things that I hear a lot. I hear this idea that, you're not really sober. You don't get to count it, as your sobriety date if you're taking Suboxone. And unfortunately, there's some AA meetings and NA meetings that reinforce that idea. So when I have a patient that's on methadone or that's on Suboxone, they really have to make sure that they look for peer support and recovery programs that are evidence-based and that are supportive of being on medication, because the medication is life-saving. Detox alone, if you look at this slide on the far left, that number 20 shows that's kind of like the starting point of how many people are in treatment. And then as you go to the right, time is passing and all those little green lines dropping down, those are people who had no medication and relapsed. And then the line at the top, the red line, is people who were either on methadone or buprenorphine and stayed in treatment. So it's just a slide to show that, if you detox somebody and then just send them out the door to go to some meetings or some counseling or some groups, it just doesn't work anywhere nearly as well for opiates as if you get them medication. It really helps prevent relapse and helps people with their recovery from opiates. So again, the medication is not a crutch. It's a tool. It relieves withdrawals and cravings and helps sort of fix the chemical imbalances in the brain. And then this is my last comment on opiate use disorder. Um, People don't have access to it, which is why I'm kind of going on and on about it. So for those of you that work with providers, it might be interesting if you turn to one of those providers in your next clinic session and said, "Hey, do you prescribe buprenorphine? Why not? Because it saves lives." I don't know if any of you would feel comfortable having that conversation, but I ask it a lot when I'm working with residents and medical students, is sort of like, tell me your fears, tell me, your concerns about prescribing, because a lot of people are afraid of prescribing, but it's so easy. It's easier than Coumadin, it's easier than insulin, so many other things we do as providers. Um, but only about 1 in 10 people get treatment. So that means about 90% of people with opiate use disorder or addiction aren't getting their care. And then that rate is worse if you're a non-white patient. You're less likely to get access to medications and get into programs. So again, that's one of the reasons that SBIRT can be so helpful, is because everybody's getting screened and everybody's getting offered access if you're doing it sort of universally for every patient every year. So I'm going to
Christina,
talk.
can I ask a question real quick?
Absolutely. Thank you for interrupting.
Sorry.
No,
For
no.
the Vivitrol, I understand they do have to be clean for 2 weeks up until that time, but can you do a substitute of like the Subutex before the Vivitrol for the 2-week period?
No. No. So unfortunately, that probably what a lot of you have encountered, or what we encounter, is a lot of the detox programs, they're covered for like maybe 3 days, 5 days. So somebody can go into detox, get lots of comfort meds, get off of their opiate of choice, and they can't get their Vivitrol because it's only been like 5 days. So I have had patients where I've given the Vivitrol early. They feel miserable, like they've had the flu. I give them comfort meds, you know, because I know that I'm going to trigger some mild to moderate, hopefully not severe withdrawal. But you can't give them the buprenorphine. You can't give them any opiates because that's just making the problem worse. Because if you're giving them opiates for their withdrawal and then trying to give them Vivitrol, the Vivitrol is a blocker and it grabs onto those receptors even more strongly than the buprenorphine. So anybody who's got recent opiates in their system, you're going to precipitate withdrawal with the Vivitrol, if that makes sense. So in the situation you're describing where somebody wants to get their shot and it hasn't been 10 days, I just have an informed kind of balanced discussion with them and say, hey, we can give you this shot early. It might, if you have lingering fentanyl in your system, which often people do, it might make you feel lousy for some days. I can give you, you know, some clonidine, some Zofran to try to help with the nausea and the agitation. But that's the dilemma. That's why often lots of people aren't on Vivitrol, is because it's just really hard to get you started on it. I've had some really motivated patients come to me and say, I absolutely don't want Suboxone. I want Vivitrol. And I only had one guy in all my years that was able to do it. And I have no idea how he did it. He was just a super crotchety old guy, and he just went home and he made up his mind, and he got off his buprenorphine, came back to me 2 weeks later and said, I'm ready for my Vivitrol shot. And we did it. And he's been on Vivitrol for several years. But
I was just asking because I worked at a pain management place that also had, you know, SUD treatment. And if they came in dirty, which more than likely they were always dirty, the provider would not give them Suboxone initially. He would give them the Subutex first because it doesn't have the naloxone in it, the Subutex. So that's why I was asking about the Subutex for the 2 week, you know, without Suboxone, the Subutex.
right. So this is a tricky one. So Suboxone has naloxone in it, right? But if you're taking it correctly, if you're putting it under the tongue, you're mostly absorbing the buprenorphine. You're not absorbing the naloxone. So the reason that Suboxone is a dual product that has buprenorphine and naloxone combined is that it prevents people from snorting it or injecting it. So, because if you snort it or you inject it, the Suboxone, then you're getting you end up getting the naloxone in your system. If you're taking the Suboxone correctly under the tongue, you're really not absorbing the naloxone. So you're just getting the buprenorphine component. So really the only time I ever use Subutex is in my pregnant patients. So, but to answer your question, it sounds like in your setting, I mean, I just kind of have a philosophical difference with the folks you're working with. Like, to me, if somebody's got substance use disorder and they come in and their urine has substances, that's not, that tells me that something's not working and that we need to have a conversation. Like, do they need more Suboxone? Do they need sober living? Do they need residential? Do they need a peer supporter? You know, what's going on? But I don't fire people for having abnormal urines or unexpected urines.
This would be on initial visit, like their initial
Gotcha.
first new patient visit
Gotcha.
is what he would give them first.
Interesting. Yeah, I guess I'd have to, and I'd have to know more, but yes, absolutely. The first urine's always full of stuff. And that's helpful because then you know sort of what your patient's using patterns are. But usually if I have a patient and their first urine is full of stuff, I don't start them on Vivitrol. I start them on Suboxone. Does that answer?
Yeah, thank you.
Okay. Sorry.
We do have a question in the chat.
Mhm.
If a patient comes to the ED for help with alcohol use disorder, can the ED staff treat them, or are these meds prescribed only through outpatient, inpatient treatment centers?
Love that question. Our ED, yes, the ED can absolutely initiate treatment. And there's lots of ED programs around the country. There's something called the California Bridge, where they have great sort of, if you're interested, I don't know where you're working, but if you're interested in trying to launch programs in your emergency room, I would go online and look at the California Bridge. They have really models that can be used across the country in terms of workflow for helping patients, both patients, like say you've overdosed on opiates and starting you on buprenorphine right then and there post overdose in your emergency room and giving you a short supply and having you follow up with somebody like me. Same with alcohol. You can absolutely get somebody started on some naltrexone in the emergency room. Again, not if they have a mixed opiate use disorder, but if they have a pure alcohol use disorder and their liver tests are fine and their kidney tests are fine, and they're telling you, I absolutely do not take any opiates of any kind, you can give them naltrexone test dose in the emergency room and then give them a shot and then get them connected to treatment. So the emergency room is a great place to intervene, because remember a few slides back, we were talking about how in the emergency room, the majority of the patients are going to be struggling with some sort of substance issue. So it's a great opportunity to help people. So good news, bad news with alcohol use disorder. It's much more common than opiate use disorder. It's really the most common substance use disorder. Number 3 cause of preventable death in the United States. We have medicine for it. The medicines work, but they don't work as well as those opiate use disorder medicines. I mean, those opiate use disorder medicines, you treat a couple people, you've got a success, which means you've also got, unfortunately, people that you're not succeeding. With alcohol use disorder, it's more like you have to treat 10 people to get a success. So the meds work, like compared to, we give people statins for cholesterol or blood pressure medicine. So they work. I'm not saying they're not helpful. It's just they're not as powerful in terms of getting success. So alcohol use disorder is much more common. We have medicines, they do work, and they help reduce the cravings and reduce the amount of alcohol used. So for the first 2 on this list, the naltrexone and the acamprosate, they work nicely. They help people stop drinking. People don't have to be completely abstinent. For that last one, the disulfiram, I really never use it. That's what we used to call antabuse. That's the one where you cannot have a sip of alcohol because you'll start vomiting and flushing and everything. So they're good medicines. I just wish they worked a little bit better, but they do work well. Somebody had a hand up.
That was me, Tamika. I guess maybe I may have missed something, or I think what's standing out to me is I'm thinking about the average drug user right now. And the average drug user, a lot of people are getting drugs off the street, but a lot of people are smoking weed, okay? And after talking to one of my friends who's a physician in Tennessee, she was sharing with me that a lot of these drugs that are out on the street, whether it be cocaine, whether it be marijuana, they're all being, basically, some of them are being grown in fentanyl, okay? And I'm thinking about the average person on the street that's buying street drugs and not going to a dispensary to purchase their drugs. They have no idea that there is products out here that they can test their drugs with to see if they're laced with fentanyl. And my first time being on the first call, I think I was sharing that I had lost an extended family member. They pulled the plug on them that same day that I was in the first call, not knowing I'm walking into a drug disorder training. And in my mind, I was thinking, had he had access to those drug strips, he might still be with us today. So I'm just thinking, where is it that, you know, maybe at these dispensaries or on, you know, while they have pop-ups for cell phones and all this other stuff that you can get in the communities, are there pop-ups and tables and that can be on the streets where people can find access to these test strips?
No, it's a great question, and I am sorry for your loss. It's tragic. So yeah, fentanyl is the #1 cause of overdose death. Some of it is people who are knowingly using fentanyl because it's their drug of choice, but many times it's people who are accidentally using fentanyl because it's mixed in with their weed or with their cocaine. So I'm gonna, at the very end, I will show you slides that show you how you can order free fentanyl test strips, free xylazine test strips, and Narcan, because those things absolutely need to be distributed, and distributed for everybody. And there are organizations out there that do go to, you know, food banks and pop-ups, and, you know, there's also, or, you know, in our area, it's Project Dawn. You know, they're out there with their van. There's also, you know, the public health centers where they offer it. I will say a word about weed. If I have a patient on using THC, and we'll talk about more with harm reduction, but I will usually encourage them to get their THC from a dispensary. So in Ohio, it means sometimes people drive to Michigan and buy their THC because it's recreational there and it's cheaper. Here, you know, it's still kind of, you know, the laws are still in flux here. But absolutely knowing the content of what you're using is vital for people.
Thank you so much.
Yeah, and I am sorry again. I mean, you know, there's countries where they have easy access to testing your drug, you know, like in Portugal, where you can find out the contents of your drugs. And we don't have that here in the US, unfortunately, other than these test strips. So medications for alcohol use disorder, they do work. But because they're not super, super effective, like opiate use disorder medicines, it's really important to get patients with alcohol use disorder connected to behavioral treatment. So counseling, peer support is really important. And then, you know, if you're talking about all the other addictions like, you know, THC and meth and cocaine, we don't really have good medicines for those. We don't have FDA approved medicines for those. So in those situations, it's even more important that we have behavioral treatment that we know about, that we can connect our patients with for their addiction. So we, like I said, have great meds for opiates, for tobacco, for alcohol. We just don't have medicine for lots of other types of addiction. So getting a patient connected to peer support, behavioral health can really help them with their recovery. And then once they have recovery, help them with relapse prevention. But usually folks have to work on all sorts of skills, right? Like their coping skills and anger management and knowing their triggers and avoiding negative thinking and isolation. And so there's lots of work to be done usually to help somebody get sober and stay sober. It usually is honestly a several year process. When we are talking about formal behavioral treatment for addiction, there's something called a level of care. I don't know if people know of it, have done it. It's usually done by like a CDCA or a counselor, a social worker. It's like a 1-hour assessment where you kind of talk to the patient and get a sense of where are they at, you know, with their physical health, their mental health, their readiness to change, and then kind of help work with the patient to decide how intensive treatment do they need? You know, do they need to be in the hospital or residential, or maybe they just need like an outpatient group or, you know, some one-on-one counseling. So there are many levels of care available. I'm not going to totally go into the weeds here, but just suffice it to say that The sicker you are, usually the more intense treatment that is recommended. The milder your addiction, usually the less intense treatment is recommended, but it's always a combination of the counselor or the social worker making recommendations, and then also understanding, well, these are the patient's goals. This is what the patient is willing to do. So this is the level of care that we're going to choose. And then I can't say enough about peer support. I don't know those of you that have peer support programs in conjunction with your clinical work, but we have them in my hospital and they're vital. They have been shown to help patients with their health, their quality of life, their engagement in treatment, satisfaction. It makes them less likely to get in the hospital. And it can come in many different forms, but a good peer supporter can offer coaching and outreach. They can also help connect a patient to resources. I've had peer supporters who, often my patients with early recovery, they don't have reliable transportation. They don't have a reliable phone. So the peer supporter can drive them places to look for a job, look for housing, get Medicaid enrollment, get their SNAP or SSI benefits fixed, get a phone. So peer supporters are a huge resource. And, you can have peer supporters like we do. They work in our clinic. They sit down the hall from me. So if I have a patient that's ambivalent, like that patient we talked about at the very beginning, and they're waiting in the waiting room, I usually will just be like, come on in. Why don't you, sit and talk to Andre for a minute? I'll be with you in 10 minutes. And that gives them a chance to just sort of do a check-in with somebody who's in recovery, who can just listen and offer, support and advice. And if the patient wants that, they can offer them resources. We also have Thrive, in this case, peer supporters in our emergency room. So somebody comes in, they've had an overdose. Our doctors, have reversed their overdose, offered them Suboxone, and then hooked them up with a peer supporter who chats with them. And if the patient wants recovery, the peer supporter will drive them door to door from our emergency room to a rehab facility. We also have the peer supporters in our hospital and in our jail. So they can really be a resource to have that near peer with lived experience. And like I said, the peer supporters can also take patients to meetings and just say, hey, it's my favorite meeting. Why don't you come with me and see? It's not so bad. Maybe you'll like it. There's other forms of peer support, like living in a sober living facility. There's lots of online peer support as well. So here's a list of a whole bunch of self-help groups. You'll have access to these slides. So if you want to look at them, I just want to highlight the two at the bottom. If you have a patient that tells you, you know what, AA, NA, just not for me, there are AA and NA meetings alternatives. One is Smart Recovery and the other one is Free Thinkers. Free Thinkers is kind of like AA or NA. It just doesn't have the religious component. And then Smart Recovery is based more on motivational interviewing. But, one of the catchphrases is if you've tried one meeting, you've tried one meeting. There's tons out there. There's, meetings for older folks, for younger folks. There's women only, men only. There's LGBTQ. There's, professionals. It just, you just have to look around, and these resources can be helpful, but there's lots of research that shows that meetings work, again, particularly for the illnesses where we don't have a medication. I don't know if anybody's ever contacted or worked with their ADAMS board, but ideally, if you have a functioning ADAMS board in your county, they are somebody that you can go on to this website, get their phone number, and give them a call, and they can help you find treatment facilities in your county. These are resources that I find helpful for my patients that are in early recovery. Please give me feedback if you have better resources, because you guys are, I'm sure, much better at this than I am. And then this is the one everybody's been asking about. So you're going to have a copy of this slide, or you can, screenshot it, take a picture of it on your phone. But in terms of using, if you have a patient who is using and not ready to get sober and you want to help them stay alive, there are apps, if they have a phone, where they can basically, it used to be that a lot of people who overdosed were using with other people. That was kind of the trend. Now, unfortunately, the trend with overdoses is a lot of people are using alone. So there isn't somebody in the room to help revive them with Narcan. So if you have a patient and you're talking to them and they're sort of saying to you, yeah, I don't really use with other people, I really kind of use alone, then these would be great apps because, and they have a phone, because they can call and they'll have somebody on the line, not who's going to call the police, but who's going to be there if they stop being responsive. And they will either call EMS or they will call a person that you've chosen. So again, it's just kind of no judgment here. This is like just trying to help people stay alive. And then if you want to know about deadly batches, because there are, the overdoses often come in waves, you'll have 8 people die within a day because there's just a bad batch out there that's just stronger than anybody wanted or anticipated. So if you want to get those alerts on your phone as a caregiver, you can text SOAR to that number and you will get deadly batch alerts for your area so that you can let people know. And then finally, the one that everybody really, really wants to know, these are some options. These are certainly not all the options, but these are some options for getting Narcan, for getting test strips. You can get them. You can also give these resources to your patients. Just, the more you get the Narcan and the fentanyl test strips and the Salazine test strips out there, the more you can help prevent the overdoses. So we can take a moment and talk about a case. I want you to imagine that you're in your clinic setting and you have a patient that comes in asking for treatment. Does somebody want to read the case?
Patient is using IV fentanyl 1 to 2 grams a day, but none today, having some withdrawal. Did detox and IOP last year, but no MOU mood. Was sober for 3 months, then relapsed. Since then has tried, excuse me if I messed this word up, Suboxone, thank you.
Perfect.
Off the street for withdrawal symptoms. Wants to get sober for good this time. Has siblings on
Buprenorphine.
Thank you so much. Who is doing well. Denies current benzo or alcohol, but using THC and cocaine. HO anxiety, depression, and remote abuse. Unsure of her LMP, lives with boyfriend who is also using, but wants to quit too. What treatment would be helpful?
Thank you. And LMP is, I'm sorry for all the abbreviations. LMP is last menstrual period.
Oh, thank you.
And HO means history of. So sorry about that.
Thank you.
So everybody just kind of dive in. Let's just take a few minutes and talk about what do you think you could offer this woman?
So before any treatment is started, finding out if she's pregnant would be the first step. And then from there, discussion, depending on what the results are, discussion of what will be the best route for her. If her boyfriend is not with her, encourage her to bring him in at the next visit so they can also get treatment and help for him as well. But I think definitely the first step is trying to figure out whether or not she's pregnant.
Absolutely. Any other thoughts?
After that, addressing her anxiety and depression disorders as well. I think instead of going full blast into finding the proper treatment for her, address the underlying problems first, because the underlying problems could be the reason why she's doing what she's doing.
Any other people have thoughts?
So I love what Pat said. Yes, I will find out if she's pregnant or not. Even though I see all the underlying issues, I will also have a time to talk to her to see, what she feels that is important, what she feels the next step when I want to get her advice and include her in her plan. So I will find out what things that I don't know that's underlining that I can help you with to address those issues. And then we work out step by step, maybe treatment makes, things off that list, but hearing what she wants to be done first. Thank you.
Absolutely. You got to know her goals and what's she willing to do. Because sometimes I have people who like, my goal is absolute complete sobriety, but I'm not willing to do, all sorts of things. And then it's like, yeah. So finding out what she's willing to do and what her goals are is absolutely a key part of the first step. Other thoughts?
I would have to agree with both Pat and Kimberly, because at the end of the day, if the patient does not want the help, there's really nothing we can do. And if the patient's not ready to detox or start treatment, then maybe providing her with, the test strips or providing her with, safety numbers that if she was to find herself in a situation, she has an outlet.
Absolutely. And that's going to be more our conversation next week. Our final session is really about what do you do with the patient that's not ready? But this patient, is really giving signs that she's ready. She's sort of saying, yeah, my brother's on Suboxone. It's really working for him. I'm sick and tired of being sick and tired, so I love the idea of fleshing out a little bit. What are your goals exactly? What are you willing to do? Because sometimes people say, I want to get sober, but I have to keep my apartment and I can't go to 30-day rehab. And then, finding out if she's pregnant is totally key because, most of the medicines are completely safe in pregnancy, but you're not going to start Vivitrol in pregnancy. Certainly you can start methadone and buprenorphine in pregnancy, but it's going to affect your medicine choices to know if she's pregnant. And then getting her some mental health medicines, absolutely. And then I will say, I would do everything in my power to treat her today because the window is really short sometimes of when somebody's willing to make a change. In addiction more than in lots of other things. I mean, I worked for 25, 30 years trying to help patients with behavior change. But in addiction, you've really got this tiny window often where you got to get in there and give them options and do it when they're ready, when they're showing up. Because if she goes back home and continues using and says, oh, I'll see you next week, there's a really good chance you're not going to see her tomorrow or next week. So if you can help her today, that is really a key message. So seeing if there's a provider that can help her with medicines, getting her on some buprenorphine, some clonidine for withdrawal, Narcan to prevent overdose, getting her, as you mentioned, on psychiatric medicines, making sure she's not pregnant, and then seeing, do you want the pill? And then the provider will hopefully do these things like checking labs. And then, if she's willing, getting her a level of care, getting her a peer supporter, getting her connected to treatment. And then the big thing is all the things that you guys do all the time, which is addressing those social determinants of health. Does she have a safe place to stay? Is she being trafficked? Is she safe? So, and you're not going to get to everything at that first visit. Obviously, this would take a week to do all of this, but you can start to, hit some of it at that first visit, and form that relationship, see what she's willing to do, and do some like kind of triage crisis intervention. And like in our neck of the woods, we have, a 24-hour diversion center, which offers detox and connection to care. So that's a great resource for folks in the Northeast Ohio area. I think we had somebody from Oriana on the call a couple sessions ago. So anyway, so this is sort of one way to frame it. And you're going to just take a bite out of some of the different issues, like helping her get off the fentanyl, helping her, get stabilized physically and make sure she's safe, and then sort of working on treatment and engagement. And there's no one right answer. It's different every time. I mean, almost every day I'm at work, somebody walks into my clinic and, wants help. And, we do what we can, we triage, and then we try to, keep a really close contact with them. And again, our peer supporter is huge for engaging people. So in our final moments here, I'm going to just read these and you guys can tell me true or false, just in the interest of time. So there are no effective treatments for addiction. True, false?
False.
Yep, absolutely. There's, lots of medicines and behavioral and peer supports available. Medication for addiction is a crutch and should be avoided.
False.
False.
Yep. Medications are available to help patients stop alcohol, tobacco, and opiates.
True.
Yep. Behavioral treatment is not needed if you are on medicine.
False.
Wait a minute, you skipped number 4. I'm reading number
False.
4. You ready?
Oh,
Wait a
I'm
minute.
so sorry. Keeping me honest. Thank you. If you are taking medicines, you are not really sober.
False.
False.
Thank you. Behavioral treatment is not needed if you're on medicine.
False.
False.
Yeah. You still need the tools that you get from counseling. Level of care can guide the type of behavioral treatment that a patient uses.
True.
Yep. Peer support's a great resource for patients with addiction.
True.
True.
And the state of Ohio has lots of resources that can help you prevent overdose and get patients addiction treatment.
True.
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 Got it.